Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another important bone tumor, and that is chondrosarcoma. So let's break down the word here. Chondro is the Greek prefix for cartilage, whereas a sarcoma is referring to a malignant tumor of mesenchymal or connective tissue origin. And so altogether, a chondrosarcoma is essentially a malignant bone tumor that arises from mesenchymal cells or connective tissue cells that ultimately produces cartilage. And so that will kind of clue us into some of the key things we need to know about this tumor going forward. So if we turn our attention to the epidemiology here, this is going to be a malignant bone tumor. Remember earlier in the chapter, we talked about some of the benign bone tumors. Now we're kind of talking about some of the more malignant bone tumors. Typically, it's more common in men than women, and usually in an older population, approximately greater than 50 years old. So we wouldn't typically see this tumor in a 5-year-old. And as always, this is important to keep in mind because on board-style questions, they often give you classic patient presentations. What's the classic age range? What's the classic findings? What's the classic diagnostics? That's how they really like to test these on board-style questions. We also need to know that you can have a primary chondrosarcoma, which has an unknown etiology, and a secondary chondrosarcoma, which is typically due to pathogen disease of the bone, radiation, or potentially an osteochondroma. Now, recall, we had a whole video about osteochondroma, that this was a benign bone tumor. However, we said that approximately 1% of osteochondromas can actually turn into a chondrosarcoma, which is a malignant bone tumor. So here it is right here. Somebody who has an osteochondroma does not necessarily need surgical intervention right away, but you need to watch it closely because of that potential for the benign tumor to become a malignant tumor, such as a chondrosarcoma. Now, when we think about the presentation here, this is typically going to be found in the medullary portion of the femur, humerus, pelvis, or the bones. Remember, when we think about the bones, right, we have the cortex or the outer portion of the bone. That's kind of the hard, thick portion. And on the inside, we have the medullary portion, the spongy bone. This is where our blood cells are typically formed. And so as always, location of these tumors matters. Some of the tumors that we've talked about so far are located on the cortex, right? They grow out kind of at this portion right here. And some of the other tumors are going to be present more in the middle. Also important to note for these tumors that they can have localized pain and swelling, and this pain is typically worse at night. Additionally, these patients can have pathologic fractures. Again, a pathologic fracture is a low energy mechanism that results in a fracture, which you would not typically expect to see in otherwise healthy bone, right? If somebody's femur snaps when they lift up a heavy box or when they step down the stairs, that's considered a pathologic fracture. A normal healthy bone does not break under those circumstances. Normally to break a femur, it requires a high impact trauma to the area, but stepping down the stairs is considered a low energy mechanism of action. So if a bone breaks in that situation, it's typically due to an underlying pathology or poor bone that's actually formed in the area. So it's something to look into a little bit closer. Now, when we think about the diagnostics here, we'll draw our attention to our images over here. And I want you to really appreciate two key findings. First is osteolysis. Again, we get that moth-eaten appearance. And that's what we're going to see in this image right here. You can see this is a moth-eaten appearance. There's some areas that are kind of whiter than others, other areas a little bit more dark. It kind of looks like it's been picked at or it's been eaten in this moth-eaten appearance. This is due to osteolysis, which is the destruction of the bony tissue. So if you compare it to the bone over here, right, it's just very white, looks like good solidified bone. And then you look at this right here, it's not quite appearing to be the same way. It looks a little bit softer, a little bit less dense. And this is the classic finding you can see in these patients. The other classic finding you can see are these intralesional calcifications, sometimes called popcorn calcifications or said to have a popcorn appearance. So if you look at our image in the corner, you can see this lesion right here, right? You can appreciate how this kind of looks like a piece of popcorn. It's a very obvious calcification or lesion within the bone. This is another classic way that this can present. So we either have the osteolysis, moth-eaten appearance, or the intralesional calcifications. Both these are consistent with a chondrosarcoma in the right clinical setting. Now, also important to know the histopathology here is going to include peripheral calcifications with hyaline cartilage nodules and malignant chondrocytes. So draw your attention to this histopathologic image right here, and you can appreciate a handful of things. So these are chondrocytes, right? These are cartilage producing cells. They're malignant because we're producing too much, right? Remember, chondrosarcoma is a tumor with too much production of cartilage. And so whereas a chondrocyte is a normal cell in the body that's producing cartilage that we want, a malignant chondrocyte is one that's overproducing or producing too much of something, creating a cancerous lesion. Now, these patients are also going to have what are peripheral calcifications, and that's what you see right here. And so you see kind of this normal appearing bunch of cells over here, free floating, and then you kind of see this super dense area. This is an area of calcification, which is a classic finding in a chondrosarcoma. When we think about the management for these patients, recall this is a malignant bone tumor. So surgical excision is often needed, plus or minus chemotherapy and or radiation therapy. Overall, it's important to note this has a low metastatic potential. However, even though the risk is low, the risk is not zero, and so it still needs to be treated accordingly to help these patients in the long term. So a potential vignette they could give you for this type of pathology includes something along the lines of a 68-year-old patient presents to the clinic with 2 months of right leg pain that is worse at night. The pain is most notable in the distal thigh, and there's a mild effusion on physical exam. Vital signs are within normal limits for this patient. An x-ray is taken of the leg and knee, which shows multiple cystic lesions in the distal femur. Question can then ask which of the following is the most useful to treat this patient's condition. They could give you a lot of different options. They could talk about pain control. They could talk about watchful waiting. They could talk about some invasive testing or imaging. But the best answer for this particular condition would be to refer this patient to an orthopedic surgeon or an orthopedic oncologist for potential surgical excision. Now, I know a lot of times on board style questions, we say, you don't typically want to refer, right? It's kind of a classic test taking strategy. Usually referring to a specialist is not the first thing you want to consider in a board style question. But if you can rule out the other options, right? If you know this patient likely has a chondrosarcoma based on the classic findings that you heard about in STEM, you know that pain management is not going to be enough. You know that more imaging is not necessarily going to treat the patient's condition. This is a type of malignant bone tumor. That's what they want you to appreciate. A malignant bone tumor likely needs surgical excision and potentially some oncologic therapy as well. So in this instance, if you can rule out the other options, it would be best to refer this patient to a specialist to help treat their condition. So just a quick summary of this video, we're talking about the chondrosarcoma, a malignant bone tumor that typically occurs in older adults. Primary chondrosarcoma has an unknown etiology, but secondary chondrosarcoma can be due to a variety of conditions such as patch disease of the bone, radiation, or that osteochondroma. Remember, about 1% of osteochondromas, which is a benign bone tumor, can become a chondrosarcoma, which is a malignant bone tumor. When we think about the presentation here, this is typically going to be in the medullary portion or the middle area of the bone rather than the cortex on the outside. As with a lot of other bone tumors, this can present with pain, swelling, or pathologic fractures. Diagnostics, 2 key points to keep in mind: the moth-eaten appearance that you can see or the intralesional calcifications with the popcorn appearance as well. Histopathology is going to include malignant chondrocyte as well as areas of calcification. And the management for this condition is going to typically include surgical excision with or without some chemotherapy and radiation. So the key here is that patients need to see a specialist for this condition because it's a malignant bone tumor for further workup and evaluation.